An immediate reconstruction is more commonly performed with very early cancers or DCIS, so a or pre-invasive cancer situation, ductal carcinoma in situ, which is one of the most common findings in the screening mammography. It's the ideal time to perform an immediate reconstruction, as there is very little risk of radiotherapy being needed after the surgery. Radiotherapy can affect the skin of the chest wall and the other tissues, the fat and the muscle of the chest wall, in a way that creates some scarring internally and on the outside. And that scarring really tightens up the tissues and also affects the blood supply. And it's this blood supply that's crucial for any form of reconstruction, whether that's a reconstruction that relies on an implant or on one's own tissues. Therefore, should someone have or be planning to have radiotherapy, it's often advisable to delay the reconstruction until after the radiotherapy has been given.
The advantage of having it at the time under the same general anaesthetic, which is have the mastectomy and the reconstruction, is that a woman goes to sleep knowing that her breast is going to be taken off for breast cancer, and when she wakes up she has a breast in place. Though it may not be like the real thing, there is a breast reconstruction in place. So that advantage is there. However, there are certain cases where this can't be done. For example, patients who need radiotherapy, but again, indications for that worldwide is changing. We're finding that certain types of breast reconstruction will withstand radiotherapy much better than others. For example, just broadly speaking, implant-based reconstructions the patient will have problems with that reconstruction after radiotherapy, namely the capsular contracture, which is the scar tissue around the implant, squeezes the implant and makes it go hard. Whereas women who have autologous reconstruction, that is using just their own tissue to have a breast made, will find that after radiotherapy, it's able to withstand the radiotherapy much better, and therefore the scarring, or what we call the fibrosis, within the reconstruction is much less.
Certainly if a lady would like to wake up after a mastectomy and have their breast reconstructed, that's a very real option, and NICE recognises that. But there is a caveat to that. Certainly a lady will be going to sleep with a normal breast with cancer in it and wake up with something that's totally different. A reconstruction can't mimic totally the breast that they had before. If you delay the reconstruction, a woman will have a normal breast that's mastectomized potentially and go from normal to nothing, and then a reconstruction will give something of a normal breast. And so if you take 100 women that have had a delayed reconstruction, they're almost more accepting of the result. But if you look at the result of 100 women who've had immediate compared to delayed, and ask plastic surgeons which was the best reconstruction, the majority of them would say immediate reconstruction looks better.